All right, so recording's in progress. If anybody didn't consent to be recorded, now's your time to hang up and disappear. But other than that, we're recording, so we're starting. I am assuming that more people will roll in, which means that I will have to stop talking, which will make for a strange recording for people on YouTube to watch later. Which is why Dr. Waggle says, don't be
late.
Yes, Sarah Faith. Okay, yes, don't be late because it interrupts the recording. But everybody that's listening to me right now is clearly on time. So I'm preaching to the choir. You guys are like, what are you talking about, Dr. Waggle? I'm on time. It's the people that aren't even here. Two more people entered. All right, we'll see. Oh, there are three of them are the same person. That's some people like to join on multiple devices. I guess okay, so I'm gonna have to continue stopping talking to let people in. So I guess I'll give it one more minute, and then after that, if people aren't in, then they'll just have to watch the recording on YouTube, and then they'll have to be one of the viewers that's watching with this stopping, and then they'll be like, that is me. That is the reason that this has to be interrupted so often. All right, so we'll give it 60 more seconds. Dr. Rosenblatt, you are here, right?
I am here, yes.
Hi. Okay. Everybody is just so excited to hear from you. And let me bring up, I think it was due at 5:30, so it was due 5 minutes ago. Okay, all but three people. Well, I have to let more people in, but in their defense, it looks like this person has been trying to get in on like multiple devices. So, all but three people completed the assignment, and the assignment was to check out Dr. Rosenblatt's website, which it looks like they did, and then write a question. So I think all the people that are in the session are going to be in the session, and anybody who's not gets to watch later. And so we will start. Dr. Rosenblatt, tell us about yourself. Tell us about your practice. Tell us about how do you become ever so specialized in substance abuse disorders. We want to know all about it.
Great. Well, thank you for asking me to speak. So my name is Dr. Seth Rosenblatt. Right now, I currently practice inpatient psychiatry. I'm working for the next about 6 more weeks at Holy Cross Hospital, which is in Germantown, Maryland, doing inpatient psychiatry. My undergraduate degree was in psychology and Spanish. So I went to Rice University in Houston, Texas. I grew up in Long Island and went to high school there and then moved to Houston to do undergraduate. I then at that point moved to DC. I went to George Washington University School of Public Health at that time and got a master's degree in public health and international affairs because I was interested in global health and doing global health work for HIV prevention. And so I finished my graduate work and then I started to work for several years in global health. So I worked for several non-governmental programs with Johns Hopkins University doing reproductive health, globally doing mostly program management and program coordination. After doing that for a few years, I was interested in the clinical side of things, working with the public health physicians and being able to be more understanding the clinical background of the public health interventions. So at that point, I went to medical school at George Washington University. I was interested in primary care initially. I was in the National Health Service Corps, which I can talk a little bit more about, but it's an opportunity for folks that are interested in primary care disciplines to get a scholarship during med school or after medical school and then work with underserved populations. So I had signed an agreement after medical school to work with underserved populations for 4 years following med school, and in exchange they had paid for or they had given a scholarship for med school. I finished that. I worked initially for Whitman Walker Clinic, which is a federally qualified health center in DC, doing outpatient psychiatry. Actually, in between there, I did psychiatry residency also at George Washington University and kind of seeing a pretty diverse population there. A lot of folks with substance use kind of also tied in with social or psychosocial issues, including housing issues, access to food and healthcare issues. But finished that, then I worked for several years at federally qualified health centers in DC and Baltimore. During that time, I worked pretty extensively on using or folks using substances. So I worked while I was at Whitman Walker on their Suboxone program. Suboxone is a medication that's used to treat folks that have opioid use disorder. We can talk a little bit more about that. And then I worked in Baltimore for about 2 years at a federally qualified health center, also helping to oversee their substance use treatment disorders program. Throughout that time, I gained my hours to be able to get certification or get board certified in substance use or addiction medicine. I took a board exam in addiction medicine after gaining, I forget how many hours, but it was several thousand hours of patient exposure in substance use disorders, and took the addiction medicine exam. Right now, I practice as well as the hospital. I'm doing private practice psychiatry, and we'll be doing that full time as well in October. But I also, as you all know from reviewing the website, had started an outpatient treatment center called Vive Treatment Centers. What this is an intensive outpatient substance use program. And so we have a pretty intensive treatment that involves evening groups usually. So there's group sessions about 3 times per week run by a certified addiction counselor. There's individual sessions. There's family. We don't have any family sessions at the moment, but there's sessions discussing and focusing on family dynamics. We talk about relapse prevention, early recovery. Some folks will talk to me about psychiatry as well if they have co-occurring disorders as well, which means they may have some mental health issues or concerns in addition to the substance use piece. And so we're still in the process of recruiting clients. The biggest challenge has been the regulatory framework. DC has very stringent rules as to whom can get a license as a substance use facility. And so we are still working on that and fulfilling our licensure requirements. To get to do that, we have to be accredited by a commissioning body, and they're coming to do their final site visit next week. So a lot of exciting things going on, but I'm just excited to talk to you about them all with Dr. Weigel, and glad that you are all here.
Wow, Dr. Rosenblatt, you are very impressive. You have many, many letters after your name and many degrees. International affairs, that must have been quite the interesting one. I mean, I know what I'm interested in. I want to know more about Suboxone, but I can talk to you anytime. We'll let the students take over. I think DT, if you're here, well, actually, all of you guys did have questions, all except the 3 that didn't do the assignment. So why don't you guys practice your public speaking and practice your not being shy and volunteer a question?
So, hi, Dr. Rosenblatt. So, thank you so much for your insight on all of your hard work. So, I actually had a question about how do you prevent patients from having relapse after their treatment?
Great. That's a great question. So unfortunately, with substance use, there's no, it's a chronic disease. So I didn't talk a lot about that, but basically similar to diabetes or high blood pressure, folks that have a diagnosis of any sort of substance use disorder, whether that's opioid use disorder, alcohol use disorder, marijuana use disorder, anything like that, is a chronic disease, meaning that if not treated, it can reoccur. So what you mentioned, relapse or kind of returning to use. Kind of the best way to do that is to help folks understand their triggers. So what is driving them towards substance use? Understanding alternative coping mechanisms when those triggers do come up, connecting them to sober support networks. So whether that's 12-step programs in the community or folks in their network who are not using to re-establish their social or their sober supports. If they do have alcohol use, there are some medications that could potentially be effective in helping to reduce cravings for alcohol. One is called naltrexone. There's also a medication called Camprol. Naltrexone also has an injectable form that folks can use once per month, which is called Vivitrol. Again, neither one is a magic bullet. It's not going to magically stop people from relapsing, but it is a tool that can be useful to help. And then if folks have opioid use disorders, whether it's heroin or fentanyl or any other opioid, Suboxone, like Dr. Weigel had said, may be helpful in preventing cravings and helping folks to continue to work on those other things I had just mentioned to help prevent relapse.
And we can't forget my right here, the Narcan spray. Not that it prevents relapse, but it definitely, especially in the public school district where I am, with 9 kids overdosing. They actually just emailed our school district the other day about everybody having these on hand. So talking about those medications made me think of that. And the acamprosate, which makes you throw up if you have alcohol. So that's a fun one. So Aditi, you actually got 10 extra points today because you were the first one to volunteer. So I know that you guys had more questions. So who's gonna go next?
Hi, I would like to go next.
Now,
Hello.
Millie, as I said before, I understand your generation, the Zoomers, but I do like to see people's faces. I'm just saying.
Sorry, I would try to, but I'm not able to right now because the area I'm at is quite busy.
Okay, so we don't want to see all the people running behind you, but I'm just letting you guys know for future reference. Dr. Waggle likes to see your nice smiling faces. Okay, Millie, I figured you'd be amongst the first to go, and 10 extra bonus points for you, my dear. Please continue.
Okay, hi, good evening, Dr. Rosenblatt. So I'm Millie, and my question is, what are the current emerging trends in addiction and substance uses disorders that you've noticed, and how is your ViV Treatment Center adapting to address these issues?
Sure. That's a great question. So I think working with co-occurring disorders is a huge trend. So again, most folks that come into addiction treatment tend to have underlying psychiatric illness, whether it's depression, anxiety, bipolar disorder. And so in order to effectively treat those individuals from a addiction standpoint, you also have to understand what other underlying mental health disorders are occurring or co-occurring. And so the way that I help do that, because I am a psychiatrist, I'll usually do the intake with the individuals who are entering treatment, determine if they are currently engaged in psychiatric treatment, and then determine if there's appropriate treatment needs. Medication, again, is a big one. We've already talked about that a bit, but there's antabuse, which, as Dr. Weigel said, is the one that may make you sick or ill if you start to drink alcohol on top of it. There's naltrexone or Vivitrol, which helps reduce the cravings for alcohol. There's a medication called Camprol. There's also some other medications that folks may use off-label that may be useful for treating addiction. We don't do treatment like transcranial magnetic stimulation or anything like that. There has been some recent research showing that may be beneficial in helping people in early recovery.
Oh, I'm a fan of TMS all the way, but don't let me interrupt. I just had to interject. Team TMS. Team TMS.
Yeah, no, that's I think I think community involvement is a big one in terms of up and coming, trends. So working with, make sure folks are connected into the community with any various resources that they may need, family involvement. And I think understanding the biochemical pathways involved within substance use, working to work with folks to treat those as well.
Thank you so much for answering my question.
Yeah, you're welcome. Thank you for asking.
Yeah, Millie, that was a really good question. All right, we want to make sure that everybody who really wants to get their questions answered goes. So let's see who's going to be next. And remember, the first couple people do get bonus points on their grade.
I have a question.
Sarah Faith, bonus points. Let's hear it. Oh, and well, I like it's like a silhouette, but it definitely I like the mystery. Okay, Sarah Faith, let's hear your question.
So I saw on your website that you specialize in LGBTQ psychiatry. I was wondering what type of training slash certification does that involve to be able to work with that community, and what are the differences in non-LGBTQ psychiatry and LGBTQ psychiatry?
Sure. Great question. So there's no academic certification. So in terms of psychiatry, there's no fellowship or, training after medical school or anything like that, or any special certificates or programs that you would do, as far as I know, to specialize or focus on that. It mostly comes from experience and research working with that population. So like I had said, I worked for about 2.5 years following following residency with Whitman Walker Health. For those that are unaware, Whitman Walker is a federally qualified health center in Washington, D.C. that serves D.C., Maryland, and Virginia, that focuses specifically on LGBTQ individuals. And so they do a lot of work there in terms of primary care, working with transgender individuals, providing medical care for that population, psychiatric care for that population, working with the underserved as well. And so that's where some of my experience came from. Additionally, in my private practice, most of the clients that are seeing me do identify in that population. And so it's mostly experiential. In terms of the differences, I think there's a lot of cultural differences and sensitivities that come with understanding how to work with that population and exposure with that population. One would be the unique health challenges that LGBTQ people face in terms of increased rates of substance use, increased rates of tobacco use, increased rates of infectious disease like HIV and sexually transmitted infections, understanding that just being in that population places them at higher risk for those health concerns, understanding, although I may not be part of a specific population, understanding, for example, the path that a lot of transgender individuals may take in terms of identifying, and then the medical treatments, both hormonal and non-hormonal, that they may need, understanding the basis of that. A lot of times mental health professionals will work with folks pre-surgery to get approval for the surgery in terms of writing letters supporting the individual. And so I think a lot of it just comes from experience working with that population and being sensitive to their needs and understanding the various challenges that they may face.
Yeah, I wanted to comment on the cultural sensitivity because Dr. Rosenblatt and I went to the same med school, and I remember they really drilled into us when actually asking like sexual health. Do you have sex with men, women, or both? Remember that? And we were drilled in, and that was how we approach it. Because I mean, I've only ever gone to one medical school, but I do think that maybe some other medical schools aren't as culturally sensitive and don't use like the correct terminology for different things. And I think where we went to medical school was really good at the cultural sensitivity standpoint for that population. And I just wanted, I mean, the first thing when Sarah Faith brought up that question, it was like men, women, or both, and it just really resonated with me from medical school. So thank you, Sarah Faith, for that question. Who is going to go next? And this may be the last person to get the bonus points.
Oh, thank you for answering my question.
I had a question.
All right. Oh, Jade, and your camera's on. Okay, Jade, let's hear it.
So my question was, how do you navigate treating addiction and substance use disorders while also treating mental health disorders like medicinally if needed?
Sure. So again, usually, thank you for the question. Usually a thorough intake is the first step to understand if a patient is receiving currently, before their substance use treatment, any psychiatric treatment, if they've had any past psychiatric hospitalizations, kind of taking a thorough psychiatric history, as well as understanding their current substance use history and how the two play into each other. A lot of folks that do come into treatment for substance use are already on psychotropic medications. And so making sure that the current medications are correct in treating their symptoms. Sometimes it's difficult because if folks are using substances and taking medications at the same time, it's hard to know what their mental health symptoms are really like in the absence of substances. A lot of substances will exacerbate certain symptoms, cause increased depression, anxiety, things like that. And so for a lot of folks in early recovery, it's challenging because they don't have a true grasp on their emotions and feelings and symptoms off of the substance. And so certain things may get worse or better in terms of some of their mental health symptoms. So having a full understanding of the patient's history, working with them during treatment to perhaps, if they're not working currently with a psychiatrist, they should be working with a psychiatrist fairly closely to make medication adjustments or start medication if things become more of a problem or issue for them and it's appropriate for them to start medication or continue on whatever prior medication they were on if they are finding it to be useful for the symptoms. But I think a lot of it is observing in the absence early recovery or in the absence of the substance in early recovery, kind of what symptoms they're experiencing and what the appropriate treatments would be.
Okay, great. Thank you so much for answering my question.
Thank you for speaking up, Jane. 10 extra points. 10 extra points to Gryffindor. Okay, who's next? Sorry, I love making corny jokes. It just highlights my day. Okay. Who's next?
I have a question.
Okay, Gatali.
So
Oh,
you-
Gatali, I'll give you 5 extra points,
Okay.
okay?
So you've talked a lot about how you sort of served public health throughout your journey in medicine, and I was wondering what considerations you had when you were considering like pursuing your master's in public health and what you would offer as advice to other people who may consider a similar path, as well as pros and cons to pursuing that extra degree and doing that path.
Sure. Yeah, it was a long time ago that I did my public health degree. I actually did it before medical school. There are some folks that may do it during medical school or after medical school. I think anywhere that you do it, it is valid. I think it may provide a different perspective if you do it prior to medical school, kind of understanding medicine from more of a population perspective as opposed to the individual patient. I chose to do public health because at the time I was not necessarily interested in clinical medicine and didn't at that time have an idea that I was going to go into clinical medicine. I wanted to do something where I would be working with the public in a helping profession. Public health is great because there's so many different avenues you can consider with it. There's epidemiology, there's health programs, there's global health, there's domestic public health issues, there's nutrition, there's uh, uh, mental health. There's kind of so many various avenues you could pursue if you do go into public health. One thing that may be worth thinking about is the financing of the degree. Some medical schools will have as part of their program where they'll pay for some of the degree, which it can be, even though maybe an expensive degree to obtain. It's usually 2 years the program, and so if someone is able to help assist with the financing, you then have to take out less loans or other payments for that. That's something to consider. I think it also depends what kind of work you may want to do. If you want a broader understanding of medicine, kind of just beyond the one patient client interaction that you're having, and to understand how medicine fits in the broader context of populations, other folks in the country, different demographics, understanding statistics and biostatistics, things of that nature. I think it's a great degree to pursue.
Thank you.
Dr. Rosenblatt.
Yes.
It's so funny calling you that because we're friends, so I don't actually call him that in real life. But Dr. Rosenblatt, when you say the medical school will help pay for it, the degree in public health, do you mean that the tuition is combined and therefore you end up paying less, or do you literally mean that medical school would pay for your public health degree?
I don't know, so I don't want to be
Well,
quoted.
I know because you got your public health
Yeah,
degree
I did
first
it
and then went to
before.
medical school.
I think there's some places where it may be included in the tuition. Like I think George Washington had something where you could take public health classes and not pay extra tuition. I don't know if certain medical schools have arrangements where they'll provide like scholarship for a year or two if you do a public health degree. So I think folks would have to probably do further research on that.
Or I think one way that they actually make it more affordable is classes that would be similar that you might take for one degree and another, then you only have to pay to take one class instead of paying to take them double. So yeah, those are good things to think about ahead of time because maybe you could save money doing it one way as opposed to another. So thank you for that. All right, so we probably have time for a couple more questions because I know Dr. Rosenblatt's very busy. And I do want to save about 15 minutes, so at about 5:15 for the end, because Shri did tell you guys that we were just gonna answer a couple lingering questions since this will be our last meeting for the summer, but the fall interns will still get more meetings. But I just did want to mention that only a couple more questions because I know all of you guys had questions. Well, except for 3 of you. All of you guys had questions, but we'll have time for only a couple more so that we can make time for just some housekeeping stuff for the internship at the end. So, all right, who's going to go next? Okay, we will do 5 bonus points. We're still, no, not 10, but 5 bonus points.
Hi, Dr. Rosenblatt. Thank you for being here. Oh, let me turn on my camera.
Oh, Serenity. Hi.
Hi, Dr. Waddle.
It's nice to see you.
Thank you. Nice to see you guys too. I had a question about the intake process. So what does that process look like when discerning what type of treatment a person needs?
All right, so usually the intake, it's a good question because I think it's an important part of the process. Usually the intake is to confirm that they're appropriate for intensive outpatient treatment. And so there's some cases where an individual may not be appropriate for outpatient treatment. For example, if they're undergoing active alcohol withdrawal or any other physical problems or medical problems where they may need to be in a hospital or inpatient detox center like residential program. If they have continuous relapsing and have not had any, periods of sobriety, they may be more appropriate for an inpatient program. But determining that they're at the right level of care, the American Society of Addiction Medicine determines or has different levels of care. One of them is the outpatient level of care. So the intake asks certain questions about their use history, their use patterns, any physical symptoms, any hospitalizations they've had, any medical and legal complications, social supports, to make sure that they would be appropriate for an outpatient setting. Again, it kind of is pretty thorough, lasts about an hour and a half or so, focusing specifically again on their substance use, their age at first use, their family history, so any living relatives, if they have mental health or substance use issues, medical issues, any psychiatric treatment, any suicide risk or suicide screening is part of it. Mental health screening is part of it. So doing addiction or depression and anxiety screening, like I said, medication history, understanding their family dynamics, their current social relationships is all part of the intake process, and then discussing with them their appropriate treatment plan.
Well, thank you. I do have a mini follow-up question, but it'll be quick because I'll be respectful, I promise. So let's say they do get into your program. What does it look like after that? What are the care steps?
Sure. So again, it's intensive outpatient treatment. It lasts about 8 weeks, depending on the severity and things that clients are dealing with. The program consists of group and individual sessions. So the group sessions are 3 hours a week. They're 3 times a week with the addiction counselor, again, focusing on relapse prevention, early recovery skills, understanding your use patterns, triggers, understanding life in sobriety, things of that nature. And then after that, there'd be step down from the intensive outpatient to an outpatient program. Right now, since we're newer, we don't particularly have any outpatient treatment, but I would refer them and make sure. There's also individual therapy as part of the plan, so making sure that they meet with the individual therapist to do their treatment plan, which involves specific goals and objectives, a lot of times connecting them to a sober community, making sure that they have resources in the community to maintain sobriety, and then reviewing their treatment plan with the therapist every week or so.
Thank you so much.
Well, I have a follow-up question to that because one of the trickier things that I do in my clinic is when somebody does require that higher level of care is convincing them to go to it. So Dr. Rosenblatt, you had said that some people may be more appropriate for inpatient care. How do you go about breaking that news to them? Because I find when I tell people that the best treatment that they can get for their specific situation is a higher level of care. So this is just for the students. So like different levels of care, the basic standard outpatient, just like checking in with psychiatrists. And then you would have intensive outpatient, which is what Dr. Rosenblatt does, right? It's mostly intensive outpatient. You wouldn't qualify it as partial hospitalization, correct?
No, so there are some folks that do intensive outpatient programming. Partial hospitalization is usually every day. Would probably be for the 3 or 4 hours. I just don't have the resources right now to do that. I think that's in the future horizon.
Right. So partial hospitalization would be the next, and then the highest level of care is inpatient. So Dr. Rosenblatt, do you have a specific referral list, or how do you tell people that they would benefit more from inpatient care?
Right, so I think it depends a lot on their resources and their insurance. So again, I try to do a screening prior to when they come in on the intake to make sure that they don't have any active reasons why they'd have to be initially referred to inpatient care, like if they're not looking for detox or they're not looking for a residential inpatient program. Although you're right, sometimes people enter the program, they continually relapse, they continuously, are not thriving in the outpatient setting, and usually you just have to, like you said, break that news to them. I think we're not fulfilling your needs it's in your best interest for your safety and your health and your well-being and the optimal outcome for your recovery, that we would need to refer you to an inpatient treatment center. I do have certain centers that I have connection to, so I would call them. DC has what they call the Assessment and Resource Center, which you go to. You have public insurance in DC, and they will connect you to inpatient treatment usually the same day. Otherwise, I would work with the patients and their insurer to try to locate an appropriate inpatient treatment center. But there's a few that I would refer people to.
All right. Well, I will not monopolize the questions. It is time for a student to ask a question. Oh, come on. Google Classroom has 33 questions. All right. So also, I'll start subtracting points off of everybody's grade until somebody speaks. All right.
I had another
Everybody's getting.
question.
Whoa. Okay. All right. Yeah. Well, I'll give
So,
you extra points. You saved the
um,
whole class from minus points, Jade.
oh, okay, great. I just had another question regarding more of like the financial part of this treatment center. So, I know there's obviously like in DC, like there's this big span of people in different financial situations, and so there's a large group of people that are homeless or dealing with poverty. So, how do you deal with, like, for example, if somebody were homeless and they just needed some treatment, like, is it
Sri, mute your microphone. I'm gonna
Is
boot
it-
Shri out of
I don't
here.
know. I already asked them, and then they were like,
How do I?
"No, she's still factoring to those."
Shri,
Yeah,
mute your
Wait.
microphone.
Okay, sorry.
Shri's the intern coordinator, everybody. Continue,
Just
Jade.
like, how do you deal with that? And is it like purely only under like insurance, or like how is the financials kind of?
Great. Yeah, and that's a good question. So right now we are not participating, unfortunately, with DC Medicaid. Medicare, so the reasoning for that, DC Medicaid, unfortunately, their payment is just not for a 3-hour intensive outpatient treatment center. I think they reimburse very low amount, something like $60 for the session. Which doesn't, unfortunately, unless you have very large groups, make it financially feasible. Although, like you're saying, I would like to take and treat those people because they're the most in need. Luckily, like you said, DC has other availability of resources that I would definitely refer that population to. In terms of public or commercial insurances, we are in the process of getting credentialed in network to accept those. The process, and again in DC, has been quite laborious. You have to first receive a license from the district to operate a substance use facility, and to get that license, you have to be accredited by accrediting body who has to come to your site and do all sorts of things. Once you get that, then you can apply with the insurers with your license or the state license. But yeah, that's a huge issue, accessibility. Unfortunately, there's not too many facilities in the district that do accept Medicaid. I think part of that is a policy issue. If folks worked with DC Medicaid to perhaps increase the reimbursement rates, I'd be much more open to accepting that. For some reason, their reimbursement rates for actual psychiatric services and medication management are not as poor for some reason. For the facility fees, what they reimburse for intensive outpatient substance use treatment doesn't make it feasible unless you have significant large groups.
Okay, yeah,
I mean,
thank you.
I get it, Dr. Rosenblatt. I'm sure maybe the students, but I personally understand what you're saying there. Good question, Jade. I think Serenity did want to ask more, which I just gave you 5 extra points for that. But I definitely, for those of you that need to work on your participation grade, you have 5 more minutes to do it. So let's not be hesitant, because if you want to go to medical school, there's going to be so much public speaking and so much rounding, and now's the time to get used to talking in front of people. So, Gabby has one.
I was gonna ask, like, what are some personality traits and stuff like that that you think would be good for somebody to have that's in your line of work?
Sure. So sorry, something just happened. So I think patience is a big one. A lot of folks in mental health don't like working with substance use population a lot of the time because they have a lot of co-occurring mental health disorders. They again have a lot of psychosocial issues going on. They tend to continually relapse. They have difficulty with certain relationships in their lives, and so it's a challenging population. Not a lot of folks are competent or successful to be able to work with. So I think patience is a big one. I think being able to have high levels of empathy, to being able to understand what a person is going through, that it is a biochemical or neurochemical illness, and being able to have compassion for the person, being able to have empathy, understand where they're coming from. I think the patients, the good kind of clinical bedside manner, being able to meet the patient where they're at, being able to provide hope for the patient, being curious and able to understand how to best interview and work with individuals that face substance use disorders, I think are all good personality traits to work with this population.
Thank you.
Yeah, good question, Gabby. I did briefly do a rotation in addiction, and I found it to be like extremely rewarding and interesting. I don't focus on it in my clinic because bless Dr. Rosenblatt's heart, it is just so tough, and it would require probably like a lot of outside of the office time, because people have emergencies, and the unexpected occurs quite a bit. And so it is a very tough field, and a lot of healthcare professionals don't have what it takes. They don't have the patience, they don't have the empathy and compassion. And thank goodness somebody out there like Dr. Rosenblatt does. But that was a very good question, Gabby. And in those personality traits, a lot of, I wouldn't say a lot, but I would say a lot of healthcare professionals do have a very difficult time with addiction, and it certainly does take patience. And so fortunately, there are people out there, and there are facilities that do have what it takes, and the compassion and empathy. So, all right. One last final question.
I have a question.
All right. Let's see. Oh, okay. Okay. And your camera's on. All right. Final question. Everybody get excited.
Okay, so being so in the mental health field and in the addiction field, in the next few years, how do you see the treatment kind of evolving, and like what changes are you like thinking that um could happen, just like in theory?
Sure. Good question. I think they're looking at a lot of kind of alternative treatment. So again, it's tricky with folks in early recovery because you have to find treatments that are not going to trigger thoughts or cravings to use. They've kind of worked with like low dose psychotropic medications like psilocybin to help with addiction. They've, like I said, the TMS is part of it. Neurofeedback has a potential role. So I think kind of these non-pharmacologic, non-therapeutic kind of alternative modalities are something that's emerging into the future. But honestly, a lot of with substance use, a lot of what's kind of old has also worked. You know, the 12-step program, which again, we're not affiliated with the 12-step program, but things like Narcotics Anonymous or Alcoholics Anonymous, you know, are a free kind of community-based program that has not really changed much within the past, 50 to 60 years. And a lot of people in the community tend to utilize that as part of treatment programs and seems to still work for a lot of people. So I think kind of combined with the medication, kind of combined with the therapy, kind of combined with a lot of these newer modalities that they're maybe looking at, is the approach to treatment. But there's been a lot of research kind of on the neurochemical side of things. We're doing a lot at NIH in terms of understanding the biochemical pathways to see if there's any targets or targeted approaches. There still are not good medications for folks that are using cocaine, who are using meth. The medications really only exist for alcohol use and opioid use. And so a lot of research has been going into that. Unfortunately, there's not much profit to be derived from pharmaceutical companies focused on that population. And so there hasn't been much development there, but I think that's a trend that they're doing a lot of research on at other agencies and how to approach those other substance uses that don't necessarily have any pharmacologic treatment as well.
So great. Thank you.
Yeah, if you want the progress to happen, you have to financially incentivize those pharmaceutical companies. And I have asked you a lot of questions about psilocybin because that's been coming up a lot in literature I've been reading. But I think that's beyond the scope of the students. And it is 6:16, and we all appreciate Dr. Rosenblatt's time. Everybody say thank you. We'll let him get back because we know he's very busy, and then we'll finish up with some housekeeping, outstanding grades and assignments, and that sort of thing. All right, Dr. Rosenblatt, everybody say thank you.
Thank you.
Thank you so much.
Thank you.
Yeah, I appreciate the opportunity. If anything comes up or you have any further questions, Dr. Weigel has my information, so you can feel free to email or call or that sort of thing.
We appreciate your time.
Thank you.
Bye-bye.
Thank you.
All right. Well, that was pretty interesting. And like I was saying, I thought addiction medicine was super cool, but the level of acuity, I'm already balancing a private practice with approximately 1,500 people. And I also got a mom, I got to do the mom thing too. And people that have addiction, I would kind of need to be available, pretty much 24/7, especially if I was going to run a higher acuity facility. And so from a practical standpoint, it would have been a little bit too difficult, albeit it is something that I had a passion for and still do. Of course, I have a few patients that do unfortunately suffer from addiction, but it's just not what I specialize in. What I specialize instead is perinatal psychopharmacology, but addiction has always been of great interest to me. And I think that the world is very blessed to have doctors like Dr. Rosenblatt out there that are willing to dedicate the time that's necessary for that. So I'm glad that he was able to come and talk to all of you. And then all of you except 3. No, I just keep teasing about that. So all of you except 3 had very good questions. Thank you to those who spoke up. Those of you who were speaking up got extra bonus points. And let me get into the internship. So I think basically the sad news is that the internship is going to be over in approximately 11 minutes. But a lot of you are staying on for the fall, and some of you actually, this summer was a continuation of. I mean, there are some interns that I've had off and on for years, and I have actually taught a handful of students that are now doctors, which makes me seem really old. But yeah, I mean, there are students that I taught 7 years ago, and they're now in residency, or I don't even know if they're old enough to be attendings yet. But you guys, as long as you're in good standing and you didn't ghost or drop out or fail, you can come back at any time. If you are failing, there you have until Friday to do tons of bonus assignments. I mean, there is really, even if you had some big family emergency, as long as it is no longer occurring, you could make up the grade in the next 4 days with all the bonus assignments. Even though some of the assignments are closed, there's so many bonus assignments. There's really no excuse for anybody to fail this internship. Now, on the alternative, there's really some neck and neck competition for the person with the highest grade. Now, I know it's kind of a toxic culture to pitch you guys against each other and be like, I have the highest grade, but there will be a special award, an award ceremony. I don't know, a special certificate for the person that gets the highest grade. And obviously, if you get the highest grade, you can brag about that on all your applications. And I will be glad to opine upon it in the letter of recommendation, which is segues us to the letters of recommendation. So there, I write a lot of letters of recommendation, and what do I use to write them?
Hour log.
Hour logs, right? I, unfortunately, this was years ago, had a student who was, it was not fresh in my mind. I kind of vaguely remembered them from the past, who came back, asked me for a letter of recommendation, but didn't have their hour log. And I was like, look, I remember some of the stuff you did, but I don't think I'd be able to write a good letter of recommendation. And I said, like, can you send me? And then I guess it vanished off the face of the earth. You would think with electronics and backups and email, like, it wouldn't be a thing to lose, but they lost it. So I literally was not able to write them a letter of recommendation. So we're not going to lose our hour logs, guys. Okay. And then I do 3 months notice. And this is also to get you in the practice of giving other professors and attendings and PIs notice, because we're like really busy. I mean, I've written like probably 100 letters of recommendation, and that's definitely like a lot of time. So you got to tell me ahead of time. There's like no way. Alas, first of all, I am a little bit more lenient than a lot of professors would be. If you like push them into being like, hey, I need this next week, they might get salty with you and then make your letter not so good if you wait until the last. You don't want to tick your letter writer off. So that's just some advice for that. So August grades are going to be calculated Friday. People know what to do for the letters of recommendation. There's still these 2 mandatory fall things going on. And at some point, Shree or Riley are going to like take a poll of when people are going to be available, which I anticipate will be Thanksgiving break for these. I attached the bee sting video. Did you guys see that my daughter got stung by a bee this morning on her way to school?
Yeah. Is it better?
It's better. I actually kept her home because she's never had a bee sting before, and I was worried about anaphylaxis. So I was like, I mean, if it doesn't happen immediately, it's probably not going to happen. But there's just the remote chance that it could be delayed, and I'm just like, no, she's my child, so I kept her home and watched her the whole time for anaphylaxis. I know the movie My Girl is like way before your time, but Macaulay Culkin dies of a bee sting because he's allergic in that movie. It's so sad. Anyway, so that's at the end of there. But my daughter's doing just fine. But bee stings are no laughing matter. There is a newly assigned quiz that has to do with some of the very important for your getting into graduate school, med school, interview, ethical. I just like that. I had a really good time. I mean, I know only 16 of you got to participate, but I had a really good time with the ethical conundrums that we did. I thought that was really fun. I I think that maybe next year we could try to do more of them because they're going to be really important, because I had some really difficult ethical questions during my med school and residency interviews and things. And so practicing those, like being able to know on the fly what to say and do. Now I'm assuming that all of you that weren't making it to the cutoff round did watch the video and did glean what some of the questions would be, correct?
Yep.
Yes.
Okay. I bet it was the people that made it to the final round that just participated. Hey, Dr. Waggle knows who's participating and who's not. I'm like Santa Claus. I know. I see you when you're sleeping. I see you when you're sleeping during lecture. Okay. So I think that what we call it in medical school, we call it high yield. And when you're a medical student, you just are inundated with so much information that one of the most important things you could do is figure out irrelevance and figure out what is, quote, high yield. So high yield is a high yield. Like, we just have these phrases. And so I think that the interview ethical stuff, especially the last page that goes over the AMA code of ethics, is going to be high yield for you to succeed during your interviews. So I would definitely do that. And for that reason, I made an interview quiz. I know it's last minute, but it's just so important to your success that that's definitely going to need to be panned out. Bonus, there's a lot of bonus. Does anybody have any questions about any of the lingering bonus or assignments or quizzes? So Riley has compiled the ADHD responses into a video that I do want all of you to watch, but it's so long that it is taking us an eternity to upload it to YouTube. I would ask that at some point when we get it on there that you watch it, that and the medical devices video, because they're going to be really interesting. So I do want you to watch those. We don't have them up just simply because it's so large, it's taking forever. And then the disability accommodations, I had a colleague of mine, Dr. Diekman, do a piece that I was going to incorporate into the disability accommodations video, which I know I already had shared my really traumatizing experience with disability accommodations. I mean, I just want to prevent that whole thing from ever happening to anybody in the future. But there is a second part, which is like going over what you guys found, your rights under the ADA and that sort of thing. And then also a piece from Dr. Diekman. And so there's that. So there are lingering things. And so, if you want to just throw in the towel now, you can. But if you want to fight either to bring your grade from failing to passing, or you're fighting to get to be number one, there's going to be some other things that you can still do. And then, of course, for the year-round interns and then those who signed up to participate through the fall, I mean, there's an endless supply of fun and exciting things for you to learn. So I think I covered most of it. It looks like on August 2nd, Miriam posted the flyer in case anybody need to print it or hang it up for bonus points. One of the things that I had posted on August 1st was some of you were using ancient articles from the prehistoric times, from the 1900s. And that's fine if it's like defining something that hasn't changed. And I did put this in the Google Classroom. Whenever I started medical school, they said 50% of the stuff that we learned would found to be wrong. You have to stay current. That's why we have CMEs, continuing medical education. If you're learning something from 1999, like an article, so there's a 50% chance that that's not even a real thing. So I would really advise you guys when you're writing papers to stay current. Of course, I'm not saying that you can't use old things, but use old things for things that you know to be true. Or at least if you're using it, make sure that it's still accurate today, because when time goes by, more things become discovered, right? And so some of the articles you guys are looking at were older than me. It's like, wow, okay, I don't think so. And then also, I really don't have a preference. I'm not nitpicky about your Chicago style APA, whatever, but I do want to know the date that it was written. I don't care so much to know the date that you found it, because obviously it would be 2024 because I'm asking you to do it. I care more about when it was written. And so a lot of you guys put like 2024 because that was the date that you, and I know that that is the instruction for some of the citation styles, and I get that. But what is more important for me to know is when it was written. And I think that those are all the items. Did anybody have any other questions about any of the outstanding assignments?
I want to mention one thing real quick about the people who are interested in continuing for the fall. I know some of you guys have already emailed, and I've responded to some and I haven't responded to some. So just like send Mari and Mariam an email if you're interested in continuing in the fall, and also include like time. I can send out like an announcement about this if we need to, but include Monday through Friday or even on weekends time blocks that you would be free to do shifts, because it kind of the way it's structured in the like fall and winter and spring instead of the summer internship, it's kind of structured where like it's more of like you work as office assistants. So that's kind of like everyone's schedule is like 2 to 4 hours throughout the week, every single week, where you would be like clocking in and out of a shift. So just like keep that in mind. That's kind of how it's structured. So just email us that, and if you've already emailed us, also like just respond to that email and tell us which times each week you're available. If you don't know that yet, just like say that in the email, just because I know like people don't fully know their college schedules yet sometimes. So yeah, that's kind of the rundown on the fall intern
Sri,
thing.
you should send an announcement to that effect too, just to remind people.
Okay.
And
Yeah.
there's two reasons why continuing is beneficial. One, if you put on your resume that you did a health internship over the summer, that's one thing. But if you put that you did it for an entire year, like that's really going to stand out. The other is by far and wide, and Aditi can confirm, rotating with me not during the summer gets you way much more clinical exposure. Like people who rotate with me in the fall and winter get to shadow and come into the office, and especially because we're opening up a second location, there's going to be much more availability for more hands-on things and patient interaction. So year-round looks better on the resume, and participating not during the summer will have more exposure to clinical settings. So any other questions?
I was gonna say, I'm gonna confirm that I got to shadow Dr. Waggle multiple times. Also, like another question, are you gonna print out the infographics from the sleep sweat assignment?
Yeah, so we're doing all the compiling. We sit around a big table, Miriam and Riley and me, and we just compile. So yeah, that's gonna go up on the website. If anybody wants to volunteer, I'm transferring the improvedmedicalculture.com to improvedmedicalculture.org, because so basically improved medical culture is just like my project to kind of do things that will hopefully make less like hazing and harassment during like medical school and residency. If you think that you're like really good at like web designer, I will trust you to have the username and password to the new website. So if somebody here wants to add it to their resume or get extra hours and you're good at website design, please let me know, because well, I think in about 5 days, it's going to charge me $1,800 to keep the old website up, and it hasn't been changed in like 8 years, and it looks really old, and I would like to update it. So please let me know. All right. Any other housekeeping? Any other parting words? This isn't goodbye. It's just see you later. Let's not get emotional, you guys. You know, I really enjoy teaching, and you guys really warm my heart, and a lot of you are just so precious and dear to me, and I would like to look back and be like, oh, look at them in the future. So because like I said, I do have some students that are doctors already. Not that I'm that old, but yeah, I can't wait to see what all of you guys become in the future, because you're already such great people now. I can't imagine what you'll be in the future.
Thank you, Dr. Waggle. This was truly a really great experience. So I
Yeah. I want to say thank you so much for all the experiences, the PSI conference, and the opportunity to be a part of Improved Life.
Oh, you guys are welcome.
Dr. Waggle, what website builder do you use?
Well, I don't think Sid is here, probably because he's the marketing guy and is not interested in health. But I think it's Wix.
Okay,
Is
I
Megan?
can help then.
Because she knows about.
As long as it's not
Oh,
like
let me put you
HTML
in touch with
coding,
them.
I'm fine because I've built websites on Wix before, but I can't code. So,
No, I don't think there's any coding. I will put you in touch with them and give them the go ahead to incorporate you in on the project. That would be great.
yay, thank
All
you.
right.
Thank you.
All right, everybody. Thank you guys so much. It's been a pleasure.
Thank you, Dr. Waggle.
Absolutely. Take care.